Well, hello, everybody, and welcome to ASDEN TV. So this year, we're going to start off ASDEN TV by holding a roundtable to talk about topics of interest, topics that we all, as clinicians and as interventional nephrologists, are concerned about, and also which furthers the mission of ASDIN, which is promoting excellence in dialysis vascular access care. My name is Catheter. I'm the interventional nephrologist and the chair of the communications committee and ASDEN counselor. And with me is a very, very eclectic and educated bunch who will bring in together their own experiences on topics, because today we're going to talk about all about catheters. Catheters. We love them, we hate them, but we definitely can't live without them. So heading off the roundtable today is going to be Danny Patel, all the way from a passenger lounge in the airport. So I thank you, Danny, for joining us from the passenger lounge. I'm not going to name the airline. So Danny, if you can just give us a little introduction about yourself and just a two-liner introduction, then we'll go to the next person on the panel.
Sure. As some of you may know, I'm an interventional nephrologist practicing in Daytona Beach. I practice private practice interventional nephrology, and kind of in practice for the last 11 years, 100% dialysis access practice.
Excellent. Aisha, all the way from New York. So Aisha Sheikh, who's a superstar, social media superstar, as I've always mentioned. So Aisha, if you can just give us a brief introduction, although you don't need any.
Thank you. It's so lovely to be part of this crew. And as Karthik said, I'm based in New York City, and I'm an associate professor at Memorial Sloan Kettering and Cornell. And my background is in interventional nephrology as well as onconephrology, and I'm absolutely delighted to be part of this group and really looking forward to this discussion today.
And definitely, last but not the least, the professor in the bunch, Adrian Sequeira, from all the way from LSU. And so Adrian, if you could give us a little brief introduction of yourself, that'll be wonderful.
Thank you, Karthik. A pleasure to be here with Danny and Aisha. My name is Adrian Sequeira. I graduated from LSU in Shreveport. I'm professor of medicine. I'm also the program director of Interventional Nephrology Fellowship. I've been in practice now for 12 years, and Karthik Ramani used to be my fellow. End of introduction.
Well, I love that introduction, Adrian, and I'm so blessed actually to be joined by such a wonderful panel. Adrian, if you could to take off with the topic on bleeding catheters and how you deal with bleeding catheters, I'd appreciate that.
Well, if I don't get to see you, Danny, have a safe flight.
I'm here for now.
Can you guys see this?
Sorry, I want to add, I don't know which flight he's taking. I mean, yesterday, Richard Branson went to the stratosphere. So, yes. and I think next week, Jeff Bezos is going as well. So maybe Danny is stuck between billionaires, and maybe he's heading off to Mars. Who knows? But Danny, have a safe flight. Thank you for joining in. Really appreciate it.
All right. Can you guys see this? Thanks. Can you see my screen?
Yes.
All right. So let's see what's going on. It's not moving. Oh, there we go. So here's my case. Sorry.
Is it a stuck catheter, Adrian?
Yes. Can you hear me?
Yes.
Can you hear me?
Yes. Loud and clear.
Oh, no, it's not a stuck. Oh, sorry. I'm trying to figure out how to use it. Okay, here's the case. So this is the case since I was not in the suite.
It's a stuck slide.
It's a stuck slide.
That's what it is.
Yes, it's a stuck slide. So Karthik was kind enough to give me his case. So here's a 72-year-old male who has a history of a GI bleed. He has coronary artery disease, peripheral artery disease, liver disease, and he needed a right internal jugular tunnel dialysis catheter to be placed for dialysis initiation because he was declared as ESRD. A few days prior, he had received vitamin K for an INR of 3.3. On the day of the procedure, his INR is 1.3, his platelets are 75,000. Vitals are stable, the procedure is done, no problems during the procedure or post-procedure. Pressure dressing is applied, but 24 hours later, bleeding is noticed at the exit site. And the question I have is, how do you proceed and how do you evaluate? All right, it's stuck again, doesn't want to move. Oh, here it is, maybe this one. There we go. All right, so when we have bleeding from a catheter, it can be at 2 time intervals. The first one is immediate, so you can see it, and the other one is delayed, and this is probably going to happen many hours later. You're at home or the patient is on dialysis, that's when you will get the call. Now, the most common site that we always think is from the venotomy. That's where the catheter enters into the internal jugular vein. And so most often that's where we put our pressure dressing to prevent the bleeding. But sometimes the bleeding comes from the tunnel. And the reason this happens is there are capillaries within the tunnel. And sometimes as we pull the catheter through that tunnel to place it, we may rupture certain capillaries. And so I've always wondered, there is this vein finding machine. It's infrared. And I've always wondered, maybe we should put it on the chest and we should look. And maybe if there are no veins there, we go and put the exit site right there. And lastly, it may not be from the venotomy, it may not be from the tunnel, but the catheter you put may have a break in it. And the characteristic diagnostic finding here is every time the patient is on dialysis, the catheter will bleed. Otherwise, the catheter will not bleed. And the way you diagnose this is you inject some dye and you look for extravasation of dye, either in usually in the tunnel to figure this out. Now, one way to figure out whether the bleeding is from the venotomy side or from the tunnel is to apply the pressure dressing at the venotomy. If you apply the pressure at the venotomy and the bleeding stops, then it's most likely from there. But if it's not, then you just roll that pressure dressing down over the tunnel until the bleeding stops. If it stops when pressure is applied over the tunnel, then you know the tunnel is the source of the bleeding and not the venotomy. All right, so what do you do when you get a call like this? The first thing to do is to put the patient in an upright position. So this is known as the semi-Fowler's position. Big name, all it means is keep the patient upright. And the reason you want to do this is because it decreases central venous pressure. Remember, when you sit upright, blood from the lower extremities stay down. It doesn't go back to the heart as much as from the upper extremities, so the central venous pressure drops. The other thing you want to do is restrict hand movement or chest movement, because every time you move, you might dislodge certain clots that are formed and you might start bleeding again. Now, important here is every time you get the call, you're never prepared for this. Either you are doing another procedure, the nurse calls you, and now you got to run down. Either you're alone or you're with a fellow. Either way, you're running down without anything. And so most of the times when you go to take care of this problem, there is going to be some problem with sterility. And so it's important that you wear a mask, the patient wear a mask, and always have gloves, sterile gloves. And so most of the time, whenever I have a problem like this, I'll put the patient on bang because I know somewhere down the line, I've broken sterility. Try to catch a glove from here or a gauze from there or put a pressure dressing here, you're broken sterility. So you always need somebody to be with you. And if you're not sure, just give the antibiotic and cover the patient with at least with vancomycin. All right. So the most common thing people do is they put pressure dressing at the venotomy. Okay, so many times we have done this and yet it continues to bleed. So of late, what we have been doing is giving tranexamic acid. Tranexamic acid is an antifibrinolytic. Okay, so most of your platelets will be on antiplatelet. They'll be on anticoagulant. Okay, but what you're doing is you're preventing fibrinolysis by giving tranexamic acid. So we've done this number of times. We give 1,000 milligram bolus IV along with changing the pressure dressing. And most of the time, the bleeding will stop. If it's over the tunnel, then the ASDN manual talks about what is known as a bolster dressing. And that's basically taking your dressing and putting it in the shape of a sleeping bag and suturing it over the tunnel, okay? Now with this, you can continue if you want, just applying pressure and watching, or you can give tranexamic acid. Over the exit site, it's the same thing. Many people put a purse string suture along with pressure dressing. One of the things I always tell my fellows is make sure you take out that suture 24 hours later because that is a nidus for infection. Some people, like IR people, they will go inject thrombin and apply pressure, and usually that will stop. Some people will throw in gel foam soaked in thrombin, put manual pressure, and then put a pressure dressing over it. If nothing else works, I always give tranexamic acid. And I found so far, when I get that call at 2 in the morning, they come to the ER, tranexamic acid has done the job. Now, this is the bolster dressing. So here you can see is you have the gauze. Okay, it's in the form of a folded sleeping bag. And then you tie a suture that goes under the catheter over the gauze piece and tie it to create a tamponade-like effect over the tunnel. It's important to monitor the patient. So they're sitting, they'll be with a nurse. So every 30 minutes, you need to watch, make sure there's no prolonged bleeding. And once the bleeding is stopped, you're good to send them out about an hour or so. Sometimes if the hemoglobin is down quite a bit, you might have to give, you might have to draw CBC. So I'm going to go back and I'll show you the picture. And here's the picture of the patient who was bleeding. And you can see it's phenomenal. This is massive bleeding. All right. So in this case, what Karthik did was they rechecked the INR on this patient. It was 2.3. So they gave FFP and they gave vitamin K. So as you know, vitamin K doesn't act immediately, but the FFP will. All right. So going back here. So what I want you all to know is placing a tunnel dialysis catheter is a low risk procedure for bleeding. Better did a study, it was a retrospective study in 2016, and he found the risk of bleeding was only 0.4 if these patients were on antiplatelet agents. Prior to this, there was another study where tunnel dialysis patients, catheters were placed in patients who were coagulopathic, which means their INR was up or their platelets were below 50,000. And they found the risk of bleeding in those people also were very, very low, less than 0.1%. So while there is no clear guidelines, everything is consensus, so which means expert opinion, I would suggest that you take, you find out what is your policy in your hospital. Because the last thing you want is you want somebody bleeding and tomorrow you have a variance written against you. So many times in our hospital, there is a rule that, you know, you have to get an INR, you have to get a platelet, and there is no point banging your head against the wall. It is basically to protect you. If there is no policy like that, then you're good. You can quote literature. But in our place, sometimes they want all of these things. So ideally, you want the INR to be less than 3. Okay, so remember, this is all a venous system. We're going to the venous system. The venous system is very forgiving. The arterial is not. So if you're going to do a procedure in the artery system, an INR 3 may not be good, and INR closer to 1.5 may be better in that case. Because we're in the venous system, platelet count of at least minimum of 20,000 is required. Now remember, this was a liver patient. So if you look at the SIR guidelines, this was interesting. Prolonged INR or a prolonged PT and thrombocytopenia does not correlate with bleeding. Okay, so in liver patients, what is important is to look at the fibrinogen level, because in these patients, there is increased fibrinolytic activity. So if you have increased fibrinolytic activity, what is the drug of choice you want to give these people? Karthik? You want to give tranexamic acid. That would be better. Okay, you would want to give something that prevents fibrinolysis. So you want to give tranexamic acid. So I know you give FFP and stuff like that. So usually it is recommended that your fibrinogen level should be more than 100. Okay, and if you want to bring it to that level in a person with which is relatively normal, you might need to give 1 or 2 doses of cryo. So I think the point here I wanted to make is maybe you should try to use tranexamic acid to see if that will help you next time instead of cryo, which is very expensive. It's $1,000. So you might want to avoid that. So with that, I come to the end. Oh, one last point. So many times we start, so Better and all don't recommend we check anything, we don't stop anything. But suppose you do stop. Well, when do you restart the medication? So this is another important point. So, you know, NOACs act almost immediately, but warfarin and all those agents, they take a couple of days before they act. So I found the reasonable approach here is to have discussions with your colleagues, multidisciplinary discussion. So you want to call your cardiologist, you want to call a gastroenterologist, whoever it is you want to call and have a discussion rather than you make the decision yourself and say, start in, you know, 6-7 hours. But the important point I wanted to bring here was also that clot stabilization takes approximately 6 to 8 hours. So at least for that 6 to 8 hours, you don't want to start a medicine which acts almost immediately, like a NOAC. You can start warfarin or something like that, you should be okay. Okay, so with that, I think I come to the end.
Well, thank you, Adrian. Thank you. And I will never forget trying to mix So thank you, Adrian, for that. But jokes apart, I think it's important to, I wanted Adrian to illustrate that bleeding can be so severe. And this patient, what Adrian mentioned was for 2 days, this was just observed and nothing was actively done. But what I want to know is, Adrian, if I'm an on-call resident and if I'm a new intern, let's say, if I have a bleeder in an access, dialysis access, our default is to apply pressure right over the site of bleed. You know, we don't go to the venotomy, just like you mentioned, or even if it's a bleeder from the fistula, you know what, we just apply pressure right over the bleeding site, but we don't say, hey, let's occlude the inflow to reduce the flow. So these are excellent points to understand. The second thing which is also important to understand is the underlying comorbidities. You know, these, end-stage renal disease patients are complex patients. They have other comorbidities. They have their own, novel oral anticoagulant agents. They've got other reasons to bleed. So dealing with the primary bleeding reason or comorbidity is as important. So if I'm a uremic patient, let's say, like I had a patient last week who had a BUN of 245, and they wanted a tunnel catheter, and so would you give things like DDAVP for prophylaxis? Because if he's for uremia and uremic bleeding. So these are the considerations that should be made. But yeah, I'd like to throw it out there to both you and Aisha in terms of what do you do differently in your own institution in terms of management, and what would your message be to the general community out there in terms of how you identify bleeders in tunnel catheters and what you do?
So I think it's a little different in hospital setting versus outpatient, right? So if I have a patient who presents with uremia and BUN levels that high, and is perhaps going to be an AKI new start, we don't know if it's CKD or not, or we may, but I would start with a non-tunnel catheter, of course, and kind of not take unnecessary risks. I mean, I'm in a cancer center, and when I see platelets of above 50,000 these days, I'm like, wow, that's great. So, I mean, your mind gets used to it, and you've got to pay attention to the patient population that you're dealing with. I think DDAVP, there's no harm. I don't know how much benefit there is. The other thing is, I don't know how much ESRD patients you guys are seeing on DOACs. I didn't see that many, but in the oncology world, when they're on immune checkpoint inhibitors, a bunch of them get DVTs. And so a lot of them, if their GFRs are above 30, are on DOACs, and if they get AKI, we have to really take that into account. So I would be honest, I err towards a non-tunnel catheter. If you can avoid it, avoidance is key. Now, if you're talking about a chronic, progressive, and CKD patient who, the history and presents to your unit for placement of catheter for dialysis initiation, that's a different story. I don't think a lot of outpatient centers have access to DDAVP. Heck, I didn't even have access to the patient's medication list. A lot of times they would show up to the outpatient unit and I wouldn't know if they're on Coumadin, if they haven't started dialysis yet. So and that's kind of where Beathard study is practical, because that gives cover to people where the people are doing these procedures in the real world. I don't no longer practice in that world, but I do remember how it was. And many a times after the fact, I would find out that the patient's on Plavix or Coumadin, and but you have to do what you have to do. So I think I used to be careful with not creating very long tunnels and not doing blind aggressive dissection, trying to create the tunnel. I think keep your venotomy also just enough that you can pass the catheter. I think these practical things help. But the rest, Adrian pointed out, if you have access to antifibrinolytics, go ahead and use it. But a lot of these things are happening, out in the community hospitals or smaller centers, and you get called by someone who doesn't even know what the patient has in their neck and when it was placed. So the fragmentation of care really adds a layer of complexity to all these problems that we are discussing. But pressure dressing goes without saying, and checking PT, PTT, platelets when they are bleeding and addressing those accordingly, I think in an inpatient setting or hospital-based setting is not difficult to do.
No, I think that's absolutely important. I think thank you for shining that light on how real world practice is. Now, I know that, Adrian presented just troubleshooting methodologies, but they may not be applicable in your setting. And that's the other thing is that, please understand your local, regional, international, because we do have an international audience as well who's tuning in. So understand what is available and do that, because there may be things like that is beyond the medical, which you have to factor in when you're dealing with tunnel catheters. So thank you for shining that light on that. And Adrian, any final comments before I do a quick wrap up?
So the other thing I wanted to add, in your case with the BUN200, most of the time these people have high volumes. And so you can figure out a high volume when you put the catheter in. The vein refuses to wink at you. It's full blown, it's high volume. So that's another thing that I do. I make sure I pull up as much as you can to decrease intravascular pressure, central venous pressure. That also might help with the bleeding.
Excellent, excellent. Now, so thank you, everyone. Thank you, Adrian. Thank you, Aisha. Thank you, Danny, somewhere 30,000 feet in the air. Thank you to all the viewers for tuning in. I know it's been a marathon session, but that's what catheters are. It is a marathon. That's what dialysis is. That's what chronic kidney disease is. And hopefully, this educational session with ASDEN TV continues to shed the light on important topics in terms of dialysis access care. And ASDIN will continue to be at the forefront of promoting excellence in providing good dialysis access care throughout the region and throughout the world. So I thank you again, Adrian. Thank you, Aisha. Thank you for taking the time to talk about these important topics and giving tips to our users and our listeners in terms of how to troubleshoot these problems. So thank you once again. Looking forward to the next episode on ASDEN TV. Thank you, everybody.